Medicine at the University of Cincinnati College of Medicine. After spending 5 years in rural family medical practices in Wisconsin, she moved with her family and small children to Honduras, where she spent 2 years as a volunteer family physician with the non-governmental organization Shoulder to Shoulder. She returned from Honduras to join the faculty at the University of Cincinnati, where she is the Director of Global Health Education in the Christ Hospital / University of Cincinnati Family Medicine Residency Program. In addition, she is the Medical Director at Crossroad Health Center. She is also a member of the Latino Health Collaborative and course director for the Medical Spanish / Latino Health Elective in the College of Medicine. Her areas of interest include global and undeserved health and Latino health. We are pleased to welcome Dr. O'Day to share her insights into community-based care with us. Thank you, Dr. O'Day.
Good afternoon, everybody. I hope you're all doing okay on this beautiful afternoon. And I think am I the last speaker for you? So I'm the last person keeping you between, I guess, this beautiful day. So I'll try to finish up on time for sure, and maybe a little bit early. So thank you all for your dedication and spending the time talking about this. It sounds like you had some great speakers. I just hit the tail end of Cindy's talk, and that sounded great. So yeah, I talked with Adam and Elizabeth about what it might be interesting for you all to hear about, and this sounds like it's changing gears a little bit from Cindy's talk, but we thought it would be interesting to talk a little bit about what primary care is and how it can affect health equity. And I think this is kind of a timely topic now as we're talking about racial and ethnic equity. And I think when we're talking about health equity, there's a great solution kind of under our noses in primary care. And so I just wanted to talk a little bit about that. And so feel free to, ask questions as I'm talking. I don't see the chat box very easily. So Elizabeth or Adam, maybe wave at me if there's a question. I'm happy to kind of address questions as we go. So we'll make it really informal. So I would say that just like you all, with my experience kind of living in Honduras, as you heard about, and also I coordinate all of our trips and our partnership in the Department of Family Medicine with our partner Wukukuwak in Guatemala. And so I usually am visiting Guatemala and working there a couple times a year. And so to me, global health is local health, and I know that's what GlobeMed kind of recognizes that as well. And so I think most of what we're talking about today in the next half hour applies to domestic health here in this country, as well as health abroad and health systems abroad. So here's our agenda for the next half hour, is to talk a little bit about what's primary care, why it's important, how it reduces health disparities, what's a community health center, how they reduce health disparities, and then how we're delivering primary care in a pandemic, which is our challenge for us currently. So since all of you are interested in global health, I thought it would be really important to start with the Declaration of Alma-Ata, which was published in 1978 by the World Health Organization. This is a really important document within global health. And so if you study global health, or you're a student, or you're working in global health, you will hear people talking about this. So it's important to know about this document. And it's really actually important to read it if you can. If you're really interested in global health, it's like 2 or 3 pages long. It's really short. So I encourage you to Google it and read it if you haven't read it before. So this was published by the WHO's International Conference on Primary Care in 1978. It starts off with the kind of revolutionary at the time idea that health is a basic human right. So that's the first premise of it. The second premise is that governments have a responsibility to their populations to provide basic health services. And then thirdly, primary care is the best way to do that. So they actually have a kind of interesting definition of primary health care. They define primary health care as essential health care based on practical, scientifically sound, and socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community and country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. I really like that definition. And I think some of the really important key words in there are that it's socially acceptable, it's universally accessible, that communities are fully participatory in it, and that there's a spirit of self-reliance and self-determination. So I love that definition. So kind of based on that idea of primary health care as outlined by WHO in that document, more and more research started being done about the importance of primary care as kind of the cornerstone or the foundation of any health system. And so one of those people that did really a lot of work and is very well recognized in the area of primary healthcare and research is Barbara Starfield. And so again, as students of global health, I encourage you to kind of take a look at some of her work. She has just a huge amount of work out there. She passed away a couple years ago. She was at Hopkins for the majority of her career, and she was a pediatrician and public health researcher. So her work kind of says that there's four main features of primary care. And it's in these features that we can actually kind of evaluate how well a primary health system is doing. First, the primary health care is the first access for each need. So for patients and in a population, when they have a problem related to their health, the first place they go is their primary care provider. And so access, first of all, is really important. Second of all, primary health care is person-oriented over the long term, and it's not disease-oriented. So it's not just for a visit here and a visit there, it's for the length of a person's lifetime, cradle to grave, so to speak. And it's a whole person care, kind of as Cindy was just talking about. It's not disease oriented. So sometimes we see in global health, there's programs that are very focused on tuberculosis or malaria or HIV, kind of the big three in global health. Primary care is horizontal, and it's looking at the whole person and not just at one disease. Third, it's comprehensive. So it addresses the whole person again, and it should be able to address most needs of a person, not all needs. There's always going to be some need for specialty care for things that are more specialized or rare, but most needs should be addressed by primary care. And finally, it should be coordinated. So for those people who do need to seek care elsewhere, that they should be coordinated by their primary care provider. So we'll talk a little bit more about those. So this is a photo of Dr. Waleska. I mentioned that, or maybe I didn't mention that, I oversee the partnerships that we have in Guatemala with the organization Wukukuwak. And Dr. Waleska is an indigenous Cachiquel woman and physician who is the medical director of Wukukuwak. So she is a primary care provider. She's amazing. So how do we know that primary care improves the health of a population? Well, there's kind of three pieces in the research that shows us how primary care, and shows us that we know that primary care is really influencing and improving healthcare. One is that we know that health is better in areas where there are more primary care physicians, and that would occur either here in the US. So when we look at geographic areas where there's more primary care physicians, the populations there tend to have better health. And it also occurs abroad in countries and in areas of countries where there's more primary care physicians, health is better. Secondly, we know that people who have a primary care physician who can identify someone who is their provider, they generally have better health, they're healthier. And finally, there's some other characteristics of primary care that are associated with better health. So there's kind of 6 ways that primary care improves the health of populations. And the first one is access to care. So this is a photo of the road that one would take to get to the village that I lived in Honduras. This was during the rainy season, and this was not just one stretch. It was 3 hours of this road. And it was 3 hours if you're in a truck. If you were in the bus, it was anywhere between 4 to 6 hours. Now, I lived at the end of that road, and I lived in the health center. That was kind of like a mini urgent care that was open 24 hours a day. And the nearest hospital, though, was like I said, was like somewhere between 3 to 6 hours away on that road. So you can imagine that if that was where you had to go for your health care, was at that hospital, you wouldn't go very often, right? However, if your health center is close and in the community where you live, you're going to go there more often. And that's kind of one idea behind community health centers, is that they're in the communities where people live. And so being close and being where people live is part of access to care. It's not the only piece of access to care. Remember that when having access to care when you need it is also important. So Elizabeth mentioned that I work at Crossroad Health Center, which is a federally qualified health center or a community health center. And one of the things that we monitor really closely is how quickly someone can get in for an appointment if they're sick. If they call and they're sick, we want them to be able to get in within a day or two. And so that's another really important component of access. It's not just where, but when. So primary care also improves health of populations by providing really good quality care. So the research has shown over and over again that for the majority of issues of health problems, primary care providers provide as good, if not better, care than specialists do. Again, for less common issues, it's really important to have backup of specialists, but overall, the studies show that primary care provides excellent quality of care. So the Department of Family Medicine has an ongoing partnership with Wukukuwak in Guatemala. We usually send groups 4 times a year to see patients in the same villages. This is one of the residents who's seen a patient in one of those villages. I think he was taking care of her. She had an ulcer on her leg. And you can tell that he is teaching her actually how to kind of wrap her leg and how to care for the ulcer. And at the same time, he's kind of teaching Susana, who's the nurse right here, how to do it as well so that she can go check on the patient. And then this was his interpreter. So certainly primary care is a team sport. And so you can tell we've got a lot of folks involved here just with this one patient. So how else does primary care improve the health of populations? Well, preventive health care is huge and super important, and primary care physicians, and in particular family physicians, do this really well. Um, so the number of primary care physicians in a community is directly correlated with how quickly and how often we make early diagnoses of cancers like colon cancer, cervical cancer, and breast cancer and melanoma. This graph is showing you that if you have a lower primary care physician supply, you actually are going to find cancers later, more advanced. Whereas if you have more family physicians and primary care physicians, you're finding them sooner. So in general, primary care providers are really good at preventive services and making sure patients are getting the preventive services that they need, and not just things like cancer screening, but also screening for things like hypertension or high blood pressure, screening for diabetes, and things, and depression as well. So prevention is another way. This is Sandy. Sandy is a nurse with Wuku Kwok, and she works with us quite a bit on the diabetes program in Guatemala. And so that's another way that primary care really improves the health of populations, is through management of acute problems early, as well as management of chronic medical problems. So you can imagine that folks who don't have access to primary care, they're probably more likely to let things go, and maybe not not get attention for their problem, and more likely to end up in the emergency room and hospitalized for whatever problem it is. So we know that patients who can identify someone as their usual provider or as their primary care provider, they're more likely to stay out of the hospital. They're less likely to go to the emergency room, and they're more likely to have better control of their chronic diseases like diabetes and hypertension. And several studies report this and can support that. So for any of you who maybe volunteer with us at Crossroad, you might recognize this is Dr. Roberts. Dr. Roberts was actually one of my preceptors when I was a resident. He was a very young physician at that time. And so, but it's fun to be able to work with him now. He's been at Crossroad actually for over 20 years now. And so continuity of care is another important way that primary care improves the health of populations. And we'll talk about this now, even during the pandemic when we can't see our patients in person, he is seeing his patients by video and by phone. So in general, we know that if someone identifies a provider as their primary care provider, they're more likely to keep their appointments. They're more likely to take their medicines and be adherent to treatment. They are less likely to go to the emergency room. They're less likely to be hospitalized, and therefore the cost of their care in general is much lower because they're staying out of the hospital. They end up actually requiring less tests because that primary care provider knows them really well and doesn't have to order as many tests. Another reason why they're less costly. And they actually need less prescriptions, fewer prescriptions as well, if they have a primary care provider. Even if someone has just a place where they go, so for example, if Dr. Roberts isn't there, patients can see me, or vice versa. If patients usually see me and I'm not there, they can see him. In general, just having a place where people always go for their care is also associated with all those things, but a little less so. So if your primary care provider changes all the time, then those indicators aren't quite as good. But just having even a place is better than not. Lastly, the sixth way that primary care improves the health of populations is actually by reducing the need for inappropriate or unnecessary specialty care. So actually, Dr. Starfield, who we mentioned at the beginning, said that most people don't realize the dangers of too much specialty care. And sometimes what happens is, as you may know, too many procedures, too many tests can actually lead to more complications. And so it is really important to only do testing that's appropriate. And so therefore, in general, primary care providers can provide care for lots of patients and can refer appropriately. So what we're kind of referring to here is self-referral. So a lot of patients will want to go to a specialist without getting a referral. And that's called a self-referral. And a lot of times those are just not appropriate, and they lead to inappropriate and unnecessary procedures. So that's another way how primary care can improve health and also decrease expenditures and a decreased cost of care. This is our team at Crossroad, Dr. Van Milligan and Martrice and our nurse Bob. And they are modeling our homemade masks as well. So when we talk about primary care and health equity, all of those things that we just noticed and talked about related to primary care and the health of populations as a whole are actually magnified for vulnerable populations and for minority populations. So we know that in the US, if we have a community of 10,000 people, if we add one extra primary care provider, we decrease the death rate in that community by 1.4 for each primary care provider. But when we do that in minority populations, it's actually much greater. So all of the things we just talked about, you would just multiply them in order to see how much primary care affects vulnerable populations. So it really makes a huge difference in the health of vulnerable populations. So in particular, I wanted to shift gears a little bit and talk about community health centers and what they are and how they also improve health in populations. So the community health center movement started back in the 60s, and the goal was to provide affordable, high quality, accessible, comprehensive healthcare. What does that sound like? Primary care in the community, regardless of ability to pay. And so the community health centers are also led by the community. So all community health centers have a board, and the board consists of community members and patient family members. So they are really led and managed by the community. And you can see that over the past 40 years since community health centers began, the numbers of patients that that community health centers take care of has just grown exponentially, to the point where now they're really just a major provider of care, particularly for low-income populations. So you can see that we take care of a large number of vulnerable populations, including patients who live in poverty, people who are uninsured, people with Medicaid, and people in rural areas. Our patients, many of our visits are for chronic conditions like diabetes, hypertension, mental health issues. As I mentioned, the majority of health center patients are low income. So at Crossroad, over 95% of our patients fall below 200% of the federal poverty line. And many of our patients are from racial and ethnic minorities. I thought this was interesting here. 35% of the patients are Hispanic, 23% are African American. At Crossroad, I think about 50% of our patients are African American and about 10 to 15% are Latino, and the rest are white. So how do community health centers reduce health disparities? Yes, they do. And so usually when we're looking at this, we're looking at some large health indicators like life expectancy and low birth weight, things like that. So looking at low birth weight, and you probably know in Cincinnati, infant mortality has been a really huge issue that we've been working on quite a bit. And so a couple years ago, Crossroad actually moved prenatal care in-house in order to address that. And we now have 6 providers who are providing prenatal care. But we know that if you, in the population of African American women who are also low income, in the US, 15% give birth to a low birth weight baby. However, if you are a patient of a health center, your rate is only 10%, which is not as good as the nation as a whole, but it's still significantly better than women who are not patients of health centers. So you can see that for women who are not health center patients, they're running around 13%. So it really is impressive, the difference. In addition, colon cancer screening, health centers do a better job of colon cancer screening, and in Hispanics, if you are a patient of a healthcare center, you are of a community health center, you have a 55% chance that you were screened as opposed to a 44% chance. So in general, community health centers are doing a great job of addressing health disparities. Still have a long way to go, but we do much better than than like a primary care provider in the community. Same thing goes with mammograms. Health centers are screening their patients at a much higher rate than in the community. So how do we do that? How is that happening? There's a lot of reasons, and there's a lot of services that community health centers offer that, say, a private physician can't really offer in their office. First of all, we're located within the community. We're usually very easy to access. Most of you, I think, are UC students. And I don't know if you've ever tried to go to the hospital and find a room in the hospital. But whenever I have to refer my patients to university, they almost always get lost. And personally, I get lost when I go over there myself if I have to find certain places. It's really overwhelming if you have to find an office and you have to park and like, it's just really overwhelming. So community health centers just make it easy and accessible. They're usually in the communities where people live, and they can just kind of walk on in or take a public transportation. Our providers often come from the community, and they definitely have had training in cultural humility. And our staff comes from the community. And so sometimes our patients see staff members that they know that live in the community. At Crossroad, our guard lives in the community. One of our providers lives in OTR. So it's kind of a comfortable, welcoming space. As I mentioned, our health center is led by the community. So our board prioritizes what are important things that we focus on. We also have a lot of services, enabling services as they're called, that really help our patients. So one of them is health education. We do a lot of health education with our patients. So we have a diabetes educator who does a ton of education. We have a pharmacist who does tons of education, as well as our nurses. Some of you, I'm not sure if any of you are VIPs, which is the program at Crossroad for undergraduate volunteers. Some of you do some social determinant screening. That's where we screen our patients for issues like food insecurity, housing insecurity, violence, depression, things like that. And then we refer them to community resources that can be helpful. We also have in-house behavioral health and mental health services, which for a lot of people, there's a lot of stigma attached to accessing behavioral health. If it's in the office right next to mine, like literally out the hall and next to me, or the patient doesn't even need to leave the consult room, the behavioral health consultant just comes into them, it really kind of helps to reduce a lot of that stigma. So having that behavioral health easily accessible in the house is helpful as well. Our VIPs also help with the referrals. So like I mentioned, going to university or any of the hospitals can be kind of overwhelming. And if your doctor just says you need to go see a cardiologist and just hands you the paper, that can be kind of overwhelming to make that appointment. And so the VIPs are our undergraduate volunteers. Maybe some of you are VIPs, I don't know. They help the patients find a place that's close to home that would be acceptable to their insurance. They help them with the transportation and give them a reminder and all those things. So that can be super helpful. Lastly, we have community health workers. So a lot of health centers have community health workers. We have a prenatal community health worker that reaches out to every single one of our prenatal patients. She's awesome. Again, she's a member of the community. She lives in Over the Rhine, and she assists patients to make sure they're getting ready for baby. Do they have a crib? Do they have a car seat? She does a lot of education about breastfeeding, about infant care, about what's normal during pregnancy, helping them get their insurance, all that kind of stuff. And so there's also a lot of evidence that says that community health workers, when part of a primary care team, can also really improve health outcomes. So those are just some of the ways that health centers reduce health disparities, in addition to those other things that we talked about related to primary care. So just to kind of start wrapping up, how do we do all this in the middle of a pandemic? This has been a challenge for all of us. I think kind of the three things that we've really focused on at Crossroad and in Guatemala are first telehealth. And so community health centers around the country adopted telehealth literally overnight. So within a couple weeks, we were able to kind of transition the majority of our visits to telehealth. You can see that this is for all health centers across the country. About half, or 49% of visits since March, have been by telehealth. That means either by phone or by video. And I would say that before that, it was probably less than 1%. So that's a huge change very quickly. But I think telehealth is now here to stay. It's not going anywhere. I think our patients overall, most really like it. And our providers really like it. It is safer for patients. They don't have to leave their home. They don't have to be exposed. And it's safer for our staff. So any patient who calls in with COVID type symptoms, they all receive a telehealth visit first. And then if they need a test, we generally try to get them tested in their car if we can. So that's just limiting both our staff exposure and the patient exposure. So all other visits, even like follow-ups for diabetes or hypertension or things like that, those are also done now by telehealth. And so we default to telehealth for those. And then if a patient needs to come in for like an exam for some reason, or for labs or something like that, then we'll bring them in. But we try to have them do telehealth first. And overall, I would say most people really like that. Community health centers have done a lot of testing. We received funding from the federal government to do a lot of COVID testing. Crossroad has been doing testing since as soon as it was available. So we've been doing testing since mid-March. We continue, we've done a lot of testing over the last week as it's just kind of taking off. That's been another focus for us. We also test community members. So we work with one of the residential treatment programs, and we test all of their staff and residents every 2 weeks as well. And then we just do lots of education. We're just really trying to reach out to our patients and educate them about COVID, how to stay safe, importance of masking and social distancing, especially at this time. In Guatemala, I think our focus has been pretty similar, actually, with the exception of testing. So we've done, as I mentioned, we usually visit Guatemala every 3 months, so quarterly. We missed our April visit, but in July and now in November, we are providing services by telehealth. And so this is one of our residents, Andrea Rosado, who is providing telehealth visits back in July to our patients that we usually see in Guatemala. And WuKuKuak has been just an amazing partner, and they do amazing work in Guatemala. So one of their goals is to make sure that patients can receive care in their native language. In the language they feel most comfortable speaking. And there are lots of people in Guatemala whose first language is not Spanish, and they prefer to speak an indigenous language. So WuKuKuak developed a series of YouTube videos called Dr. Chapin. So Chapin is a nickname for a Guatemalan. And so this is Guatemalan doctor. And he has a whole bunch of videos here about like what is COVID and what are the symptoms and how to protect yourself. And these have all been translated into the indigenous Guatemalan languages. And you may know that we do have lots of Guatemalans here in Cincinnati, and many of them don't speak Spanish either. So we've been able to disseminate these videos to the Guatemalans here in Cincinnati. So that was kind of cool as well. So just in closing, I would say that we've talked a little bit about the importance of primary care, and in particular in community health centers, and what an impact that makes on populations. Unfortunately, in the US, we currently have a shortage of about 20,000 primary care physicians, and because of retirement, because of primary care physicians who are coming out, there's not as many as we need to replace those who are retiring. And because of population growth, we actually need 55,000 by 2033. So this is a plea to you too, to consider primary care as a career option. I found it amazingly flexible and amazingly rewarding, whether you want to practice downtown or in Guatemala or around the world. It's really flexible, and it's needed, and it's hugely beneficial. So with that, I'll close and just open it up to any questions or comments or thoughts from you all.
Arnora, I think you had a question.
Yeah. Hi, Dr. Adea. Thank you so much for